You guys, you can hear me? All right. So, hey everyone, my name is Harry Nonez, PGY2, and today's talk is called Just Scan 'em. So I'll be particularly going over head CTs and we'll need audience participation. So feel free to either shout out loud or message in the comments your answer. It won't be multiple choice, so shoot out some answers. So first, we'll talk about the history of CT. The first CT scanner was built by Godfrey Hansfield in 1971. At first, it was only designed to take pictures of the brain. In actuality, the first CT scan of the living brain was done on a 41-year-old female, and then it revealed a brain tumor. It was then in 1975 when the first whole body CT scanner was then built. So then we can talk about the use. So CT scanners are now used to take pictures of virtually any body part, and it has revolutionized emergency medicine. We can look at the inside of the body just as one would look at a loaf of bread, just by slicing it. Doctors now can use CT to identify diseases that we would have normally seen during surgery or during an autopsy. And now it's used to see or further evaluate any abnormalities seen on ultrasound or X-ray. So let's talk about how to read a head CT. So the first, this mnemonic, you may or may not have heard of it, but it's called blood can be very bad. And the first B stands for blood. So when you're looking at a CT scan, you need to look for any evidence of bleeding. So you'll see this usually in the acute phase as bright white area where that would signify that there's a bleed. The next letter is C, and that's for cisterns. So not many people probably look at this, but the cisterns are not really ventricles, but they're outpouchings of the subarachnoid space. So when you are looking at a CT, you need to look a CT brain, you need to look for the four key cisterns. And they're circummesencephalic, which also can be called ambient, as you'll see in the bottom here. I don't know if you can see my mouse. You can also see the supercellular, the quadrigeminal, and the Sylvian cisterns. The Sylvian sometimes can be seen in the supracellular area. These cisterns have clinical relevance for herniation syndromes, and this is where blood will tend to layer as well. The next letter is B again, and that stands for brain. So here you need to look for about 4 things. So the first one is symmetry. You need to make sure that the sulci and the gyri appear the same on both sides. And you can see that in the first picture that it looks pretty symmetrical on both sides. You then need to look for shift. So brain, air, and CSF spaces in the bone are normally symmetrical. So you need to, any shift will cause the ventricles to move either left or right. The falx should also be midline. And like I mentioned before, the ventricles are also midline. And you need to check for effacement. You check for shift, as you'll see in the second picture. You also need to look for gray-white differentiation, which is the earliest sign on a CVA. And it's usually this loss of gray-white interface that can point you towards a stroke. Lastly, you need to look at hyper and hypodensities, so bright white versus dark. Blood calcification and IV contrast are hyperdense, so they appear lighter. And air, fat, and areas of tumor ischemia are hypodense, so dark. Next letter is V, stands for ventricles. So pathologic processes can cause dilation or compression or shift of a ventricle. Dilation of the ventricle is actually called hydrocephalus, and there's 2 types. There's a communicating and a non-communicating. The communicating hydrocephalus just refers to the fact that the CSF can flow between ventricles, which remain open. And the non-communicating hydrocephalus is also called obstructive hydrocephalus and occurs when the flow of CSF is blocked along any of the passages connecting the ventricles. And treatment, actually, you can use something called an endoscopic third ventriculostomy, which creates an opening to allow CSF to flow in and around the brain. Next one is, or last one is bones. And when you're looking at bone pathology on a CT, it's best to use the bone windows. And usually when you see a depressed skull fracture, it's usually pretty easy on a bone window. But things can get complicated when it's a non-displaced fracture, because these can mimic the normal suture lines, which I've definitely have mistaken one for a suture line before. Um, and what I actually found super helpful is that if you can look for a subtle like foci of air or soft tissue swelling, it could direct you to the fracture. So as you see in this picture, the air at the top, if you see that, you'll most likely know that something's wrong, and then you'll look and you'll see the fracture. So that was pretty helpful. And then the soft tissue swelling, you'll see at the areas of the fracture itself, there's outpouchings of the soft tissue. All right, so let's take what I said and let's go through some cases. All right, so first case, you have a 44-year-old woman who developed the abrupt onset of an explosive headache. On exam, she's uptunded and vomiting. So let's get that CT, and you see this. Can anyone point out the abnormality or see anything here? Okay. So the answer is left middle cerebral artery aneurysm. And I highlighted it with the red arrow. And then I put a CTA on the side to also show you where it is there. So aneurysms usually occur at arterial bifurcations and arise near the anterior circulation of the circle of Willis. Um, Symptomatic dissecting aneurysm should be operated on, obviously, to prevent further hemorrhage and to prevent ischemic stroke, as the aneurysm can extend and block ventriculostriate arteries. To treat this, you can use an endovascular approach as opposed to a surgical approach, which has been, people have been moving towards that during the past decade. All right, next case. You have an 80-year-old woman who presented with lethargy and vomiting after a diagnostic cardiac cath. Her exam is significant for lethargy, dysarthria, bilateral upper extremity ataxia, and bilateral inferomedial gaze deviation. All right, so let's get that CT stat. And you see this. Can anyone point out what they see? I'm actually not sure if I can see the comments, but
Feel free to just call on someone too.
it's terrible. Let's see, who should I call on? Ryan Pang, what do you see?
So I see that there's some darkening of the right cerebellum.
Perfect. There you go. So this is a right cerebellar infarct. Great job. So infarcts are usually initially identified with the lower attenuation or density. They usually are darker gray in appearance. Chronic infarcts are actually like dark black, like CSF, because tissue loss from the neuronal cell death liquefies and is known as encephalomalacia. And as you can see, left is normal, right is the cerebellar infarct. Thank you, Ryan. All right, next, case 3. You have a 60-year-old African-American male, past medical history of paroxysmal AFib, hypertension, previous CVA, actually 16 days ago, and he was placed on rivaroxaban, 15 milligrams. Presents to ED with complaint of warm sensation and generalized malaise. On exam, he has worsening residual expressive aphasia, right superior quadranopsia, and he's able to follow commands, but no new motor or sensory complaints. So as you can guess, he gets a CT. Can anyone point out what they see?
There's a rightward shift in the brain.
Good observation. Anyone else? This is a specific word. Usually happens after a stroke, or can happen after a stroke.
Herniation.
This is causing herniation, yes. But the answer is hemorrhagic conversion. So you see a completely infarcted area. It's well-defined appearance with mass effect, like I believe Ryan was saying. So hemorrhagic conversion can happen after a ischemic stroke. And in this case, the patient received a unit of fresh frozen plasma and 3 doses of vitamin K. The patient didn't really need neurosurgical intervention, was discharged with aspirin therapy, and then needed further management of paroxysmal AFib. Case 4, 78-year-old male with past medical history of diabetes and hypertension, presented to the ER for urinary urgency, frequency, nocturia, incontinence at least 1 day. Exam was notable for he was alert oriented ×1. His abdominal exam was benign, but he had unsteady gait and abnormal posture. So let's get the CAT scan. You see this. Can anyone point out what they see?
Felipe wrote in the chat NPH, and Paul wrote enlarged ventricles.
Perfect. Both are great answers and are the correct answer. So this is normal pressure hydrocephalus. So this CT shows dilated ventricles. The cause of this excess fluid can either be due to injury, bleeding, infection, or brain tumor, or surgery. In order to treat this, you can do a lumbar puncture, which will usually result in improvement in gait. Then a ventriculoperitoneal shunt was then inserted, and usually symptoms should improve by that point. This particular patient recovered without any complications and was eventually able to resume activities. All right, case 5. You have a 70-year-old male, past medical history of hypertension, glioblastoma. He was treated with radiation therapy and chemotherapy 1 year ago. He presents to the ED with urinary incontinence, memory loss, decreased cognitive dysfunction, and unstable gait. So I think this patient also deserves a CAT scan. So let's see it. So what do you see? Any of my 4th years? All right, so answer is atrophy. So the ventricles are dilated, but here's the thing: you need to differentiate between this and the case before with normal pressure. So yes, the ventricles are dilated, but also the subarachnoid spaces are also dilated. which you would not see in hydrocephalus. Um, the combination of these two is usually consistent with volume loss and atrophy in this patient. So usually atrophy begins 6 to 12 months after radiation therapy, which what this patient had. Um, the patient can also be asymptomatic, but more commonly suffers memory loss, severe cognitive dysfunction, and then they may even have the gait abnormalities and the urgency incontinence that you'll see in normal pressure. Next case, we have a 60-year-old female, 12-year history of systemic hypertension on enalapril and metoprolol. And she was brought in by EMS for altered mental status. Um, the patient developed sudden severe pancephalic headache and left-sided weakness, and that the patient collapsed shortly thereafter. So what do you think? Shoot out any comments. I can't see them, so if you want to tell me what they are.
So I just wrote that the arrows are never good. If you see an arrow from radiology, it's bad.
Sure.
So, oh, somebody else was going to say something. No, okay. I mean, to me, this is blood right there with some surrounding edema.
Agreed. So this patient had a hypertensive hemorrhagic stroke. And these parenchymal hemorrhage or hematoma are centered around the left basal ganglia with a mild amount of vasogenic edema, which you'll see with the arrows. The basal ganglia, the pons, and cerebellum are common locations for this hypertensive bleed. Case 7, 50-year-old male, past medical history of hyperlipidemia and a history of a recent fall. Very general statement, so it could be anything. So let's see what the CAT scan shows. You have 3 scans here. So to make it a little bit easier, A is someone who had a sudden onset severe headache. B is a poor historian, but with increasing confusion over the past several weeks. And C is an alcoholic who was found unconscious. Can anyone shoot out any of these?
How about Jeff Olson or Calvin or KJ?
So A looks like subarachnoid, and B or C, Max already answered, is epidural hematoma, and B looks like chronic changes, maybe like on the left side, like an old ischemic infarct, maybe like encephalomalacia on the left side. Kind of.
Thank you. So we'll definitely go through those. And you were right on most of them, actually. So left one is subarachnoid. So bleeding can occur between the arachnoid matter and the inner layer. It's called the PM matter. But usually subarachnoid blood doesn't accumulate in one place. So that's why it's actually not called a hematoma. But most common cause of this is a rupture of an aneurysm. Usually rupture of an artery causes a sudden severe headache, which is often followed by a brief loss of consciousness. For B, it's actually a bilateral subdural collection. So yes, it is chronic. Subdural hematomas are usually caused by bleeding from Burgig veins, located between the outer and middle layers of the meninges. And these symptoms can develop over minutes, hours, days, months, or years after an injury. It's more common with people who are alcoholics and people who take drugs, as their blood tends to less likely to clot. Usually small hematomas are left alone, but large ones are definitely drained. Last one's epidural hematoma. These also cause a severe headache, and it could develop immediately or within several hours after injury. The headache usually disappears and returns several hours later, usually much worse. This is what they call like the brief, like, what's the word? The lucid interval. So usually they'll have like deterioration in consciousness, increase of confusion, sleepiness, coma. So that's pretty much it for those three. Next case. We have a 78-year-old woman, past medical history of hypertension, stage 3C2 low-grade endometrial carcinoma, endometrioid type. She's status post-surgery and chemotherapy, and she came to the ED today for nausea and a posterior occipital headache. All right, so let's stare into the cat, and now we'll get our CAT scan. Anyone wants to tell me what they see?
It's like masses in the left posterior brain and in the right frontal.
Perfect. So this patient has two enhancing metastases. So this patient, known malignancy, a mass in the brain is most likely due to metastatic diseases. You definitely won't have, or you're less likely to have two primary brain lesions occurring at the same time. So again, you see normal vessels, you'll see two ring enhancing masses signifying metastasis. All right, case 9. You have a 31-year-old male brought in by EMS after being hit by a brick on the right side of his head. His heart rate's 106, respiratory rate's 32, oxygen saturation is good at 97%. He's drowsy, arousable by voice. GCS is like 10. His exam's notable for right-sided lateral soft tissue swelling and hematoma. All right, so anyone wants to see tell me what they see? Robbie, Chris.
So Paul and Bing said fracture.
Perfect. Yep. So depressed skull fracture. So clinical signs of a basal skull fracture or any like skull fracture in general, you'll see CSF leakage. You may see blood behind the TMs. You'll see bruising behind the ears or around the eyes. You can also see nerve damage causing weakness of the face. Patient may complain of loss of hearing, smell, vision, double vision. Criteria for surgical repair of a depressed skull fracture include a depression greater than 8 to 10 millimeters, brain function difficulties related to pressure or injury of the brain, CSF leakage, or open depressed skull fracture. All right, I think this is the last case. 71-year-old female, past medical history of hypertension and diabetes. He's ambulatory and normally A&O ×3, but brought in from the nursing home for ultimental status. Patient was found on the floor by the nursing home staff. His exam is notable for confusion, A&O ×1, benign cardiopulmonary and abdominal exam, but the nurse alerts you that he smells of urine. Anyone says, tell us what they see?
I don't know if he moved in the scanner, but it's difficult to really read it. I don't know if there's air like where it's not supposed to be, or if that's just fluid. It's really difficult to read it.
Yeah, I agree. And the answer is actually movement artifact. So it's one, good to know when you can see like good pathology, but then also know when things are wrong. So in this case, this is movement artifact. It's this elderly patient who came in for confusion, didn't want to couldn't cooperate with instructions to keep still in the CT scan. So again, these images were taken while he was shaking his head in the CT. So the quality is non-diagnostic. You can't do anything with this. So they repeated the scan later, showed no abnormality. The confusion was due to a UTI, hence him smelling of urine, just being incontinent. So this is most likely the most common cause of confusion that you'll see in elderly patients. So that's it. I want to thank everyone who helped me with this, and shout out to all of you guys. Any questions?